Well, to take this to the next step further, can we apply it? Can we make decisions on therapy based upon changes in scans that are not detected by very, very good, very conscientious, very well-trained neuroradiologists? And because our MS center is like 4,000 patients, they're looking at MRIs, MS all day long, every day. So they are very experienced people. Let me show you 3 cases. Now, as I thought about these, and I thought about what Professor Stanley was saying, it turns out that these are patients with more chronic disease. And I will tell you that we've been able to use the icometrix platform to go back and reanalyze scans from several years ago because they met the acquisition requirements. And we now have, over time, changes in MRI scans that we can evaluate. Imagine who got started. Here we go. This is it. All right. So this is a 57-year-old woman who's been really doing very, very well. She'd been under our care for 9 years, receiving self-injecting disease-modifying therapy. No relapses, no changes by visual inspection on her MRI scan, no neuropsychological changes, no increased fatigue, depression, and so on. She'd had no enlarged and no active lesions. However, when comparing her icometric scans over 2 years, she had a 7% increase in total MS lesion volume that was not seen even when we went back and re-examined the scans. And furthermore, she's now been transitioned to a higher efficacy disease-modifying therapy based purely on what we could see quantitatively was ongoing growth of lesion size. Have the next slide, please. All right, so this is a poor fellow with Crohn's disease, been under our care for a very long time, and there's a typographical error in here that's my fault that I'll try to cover over. So he's had a 16-year history of MS that remained clinically stable and radiologically stable over the past 9 years. But his Crohn's disease had really deteriorated to the extent where he needed a partial colectomy. We took him off of his multiple sclerosis medication and put him on a bowel regimen that happened to also inhibit the alpha-4 receptor, which is sort of like adalimumab. And that went along just fine. His Crohn's disease came under great control. However, despite visual inspection of his MRI scans over several years, indicating no change at all, the fact was that his total brain volume was 3 times higher on a yearly basis than the age-corrected normative data, and his gray matter volume 5 times greater over a 1-year period of observation. Went back to the gastroenterologist and said, this cannot continue. He agreed. We put the patient on an oral medication that's both for MS, that's not only brain penetrant, but also happens to be approved, at least in the United States, for the treatment of inflammatory large bowel disease. Have the next case. So this is a patient that's been very problematic. This is a 56-year-old woman, a former IT person, very, very talented, who developed MS and had really been very difficult to keep her on medication. Adherence was simply terrible. She claimed she was getting worse. We could see no difference in exam. Even her neuropsych testing was not normal, but it was stable. And we had seen no changes in her MRI scan. For those of you who are MS neurologists in this audience, how many times have you heard, I'm getting worse, and you can't see any difference on your exam, and you see no difference on the MRI scans? The perfect example in the case. So the patient had not taken PMGs for 6 years because she was afraid of them. And what the icometric analysis demonstrated was a yearly 6% increase in lesion volume and 3.5 times greater loss of gray matter volume and 11 times greater total brain volume atrophy. It was very easy to convince this woman at this point, when she had objective information she could look at, to go on medication. So we, in really only the short period of time that we've had this technology, it is already influencing some of us anyway in our treatment decisions. And it's gotten us out of this trap of, in your heart, they're getting worse, but you can't prove it. And here there's an example of 3 admitted chronic MS patients in whom we didn't have a pathway for the next decision until we did this. And I'm going to stop there. I think I speak for all of my other 2 colleagues in thanking you. Hope this was worthwhile. As I understand, it's now time for Q&A. Is that right?